Erika Langham is a lecturer in health promotion within the public health program and a researcher within the Centre for Indigenous Health Equity Research at Central Queensland University in Australia. She lectures in epidemiology, community needs analysis, health systems, and health policy. Dr. Langham is a mixed methods researcher and has undertaken gambling research centered on the experience of harm from gambling, the influence of jackpots on EGM play, the influence of gambling environments, the potential impact of responsible gambling features, the impact of innovation of gambling products, and the development of a scale to measure the effect of stigma associated with gambling. This presentation was given at a policy forum held by Gambling Research Exchange Ontario, titled Defining, Measuring, and Mitigating Harm. It is part of a series on the real consequences of problem gambling that can be measured and potentially reduced. Erika Langham presents Understanding Gambling-Related Harm, Separating the Behavior from the Outcomes. Despite gains in public health approaches to gambling, the capacity to separate gambling-related harm from gambling behaviors, both conceptually and in terms of measurement, had not been addressed. This issue of conceptualization and measurement is one of the key areas for progressing evidence-based policy. This presentation will address the separation of gambling behavior from gambling-related harms, outlining the definition of gambling-related harms, as well as the conceptual framework and a developed taxonomy of harms, and the subsequent process of measuring and quantifying gambling-related harm so that it is comparable with other public health issues. Erika will also outline current work being undertaken to refine these measures and to further our understanding of gambling-related harm. This video has been narrated based on a presentation by Erika Langham at the GREO Policy Forum on Defining, Measuring, and Mitigating Harm on January 24, 2017. Understanding Gambling Harm, Separating the Behavior from the Outcomes. This is a very large project, and I'm trying to cover it in a short time. I'm really skimming across the surface, and I'll provide the references at the end for those who are interested in delving more deeply into the methodology and the details of what we found. First, some really important acknowledgements. The rest of the project team, we were led by Dr. Matt Brown, now Associate Professor Matt Brown. The participants who contributed to the study all the way along, particularly the treatment and health service professionals who were incredibly valuable. The VRGF, the Victorian Responsible Gambling Foundation, who funded this study, and in particular Rosa Billy, the head of research there who fought hard for this project to be funded and has championed it all along the way. And these are our disclosures on the funding for this project. Now I'll provide a bit of background on this project. I came into gambling research only about 5 years ago, and my background was in decision support systems, where I used to build micro simulations to perform highly detailed analyses. This gave me a very systems perspective on health, so I often think in terms of frameworks. The Framework for Determinants of Health at the Australian Institute of Health and Welfare, the AIHW, is one that I like, with this idea that we can separate the proximal, or more direct, determinants of health, such as lifestyle or behavior, and look towards the more distal and social determinants of health, or indirect effects such as institutional, political, and cultural factors that in health promotion we're particularly interested in. The important point here is the separation of health behaviors from health outcomes, which will be addressed throughout this presentation. The project came up about 3 years ago when the VRGF was looking for a team to look at the conceptualization of gambling-related harm. Something that had struck me as someone new to gambling research and coming from a systems and health systems background was the idea that in everything I was reading, problem gambling harm was being talked about and measured by the PGSI, which is the Problem Gambling Severity Index, prevalence rates. This seemed strange to me because the PGSI measures a behavior, and yet it was being talked about as an outcome measure. And so behavior is an important thing to measure, but it's not the end of the line in terms of implications of problem gambling harm at a population level. When we started to ask, what is gambling-related harm, we found that it was poorly defined, if it was defined at all. There was this inappropriate measure of using the PGSI as a proxy, and one of the consequences for gambling is the difficulty in prioritizing funding and resources against other health issues that have very robust measures of their population impact and harm. When we started to look at why we didn't have an effective way of defining and addressing harm and what was being done, we found there was some existing early work. Alex Blazinski in Australia, Sean Curry in Canada, and Brian Rogers at ANU, Australia National University, who are all saying similar things. We're not actually measuring harm. Our goal for this project was to build a summary measure of gambling-related harm using standard public health approaches. To do that, we needed to capture a catalog of harms. There is some debate around what is and what is not harm. We went with a bottom-up approach of talking to people who had experienced harm from gambling to look at their perceptions of harm, rather than traditional measures such as monetary loss. From there, we wanted to conceptualize gambling-related harm, and then actually measure it in terms of health-related quality of life, which encompasses a person's perception of their physical and mental health. The first step of our approach was to conduct focus groups with treatment providers and other health service professionals. We interviewed a number of people with lived experiences of gambling-related harm. We then validated our findings against approximately 400 forum posts in online gambling help websites where people were talking about their lived experiences. We came up with this definition for gambling-related harm: any initial or exacerbated adverse consequence due to an engagement with gambling that leads to a decrement to the health or well-being of an individual, family unit, community, or population. Our definition differs from the previous work of Professor Alex Blazinski, and he's got criticisms of ours and we've got criticisms of his, as to be expected, which is good because it means that through the differences, we'll move towards a more generally accepted definition. Our definition is very much about being consistent with other definitions of health, including the World Health Organization definition, but also for us in the Australian context as well, and our Indigenous populations who have a different definition of health, a broader definition. We also wanted to ensure that our definition could be operationalized towards eventual measurement, hence we referred to it as a functional definition. The main characteristic of this definition is clearly delineating harm as an outcome, rather than this idea of behavior and the conflation of behavior and outcome that has previously occurred. We wanted to separate the two very clearly. We also wanted to recognize that gambling-related harm doesn't just occur to the person who gambles, and that it can also occur to people at any particular time in relation to engagements or contacts with gambling. We wanted it to be subjective and socially constructed, and to be consistent with the broad definitions of health that were guiding most of the public health frameworks, such as the WHO's definition. We also wanted to cover the harm that occurred to affected others, other people, not just in terms of the concerned significant others and families and friends, but even people who work in the gambling industry who can be harmed from contact with gambling-related harm. We also wanted it to be grounded in public health approaches and particularly consistent with epidemiological approaches to measuring health, which examine and describe the populations at risk and the distribution of the disease within populations. The next step for us was conceptualizing harm. This was done through an iterative analysis of all the qualitative data. We ended up with a taxonomy framework, and the dimensions of harm that you can see in the vertical boxes were very clearly distinguished in the data. The ones that emerged first were the financial-related harms, which is usually the type of harm people think of when you talk about gambling-related harm. Interestingly, the cultural harms came out last. One of the reasons for that was to do with our sample, which was more homogeneous than we would have liked. This project was followed by repeating the methodology for the New Zealand Ministry of Health, and that finding around the culturally related harms actually strengthened in those data sets. We have temporal categories in the horizontal boxes: general harms, crisis harms, and legacy harms. The temporal categories were a key finding around this conceptual framework. The general harms we refer to are any harm that occur from any initial contact or engagement with gambling. It's important to note that these temporal categories do not necessarily follow each other. Individuals may not progress necessarily through all these temporal steps, and people can move within these temporal categories. We found in the data that there is a very strong sense of the crisis temporal category. These are the times when people will reach out for help, will try to change behaviors, will become engaged in criminal activity, or get caught in criminal activities. So they are a very specific individual temporal category. And the final category, legacy harms, was a really important one. Legacy harms are a reflection of the fact that even if someone stops gambling, harm can still continue to occur, and new harms can also continue to emerge. This is the area that we've been least able to explore at this point, and it's a focus for some future research. The final group at the bottom of the framework are the life course and intergenerational harms. Life course refers to a multidisciplinary approach for analyzing people's lives within structural, social, and cultural contexts. Consistent with public health frameworks around life course theory, we found that people who are experiencing problem gambling harms, either individual harms or cumulative effects of harms, were impacted in terms of life course. These are things like generational loss and intergenerational harm. The financial category of harms is usually the first people mention, which is usually to do with the fact that it's easily identifiable. What was interesting with the financial harms is that we found distinct levels of severity, and that was due to the incredible input from financial counselors who had a lot more insight on that. The relationship harms are a powerful group, and an interesting point about these was that when we spoke with people who could be anywhere from 8 to 10 years without gambling, who were in recovery and treatment, the relationship harms were the ones that haunted them the most. These were the biggest regrets, the ones that were still impacting them in powerful and pervasive ways. People normalized financial harm, normalized or accepted or resolved what they had lost in terms of money. But the relationship damage stuck with people, and we believe that is an important category of harms to consider from a policy perspective. The emotional harms similarly had that very pervasive and ongoing impact. Shame and stigma are important effects that we are still trying to understand more about. Shame and stigma, unfortunately, are like a force multiplier for harm. Take any other harm, add shame and stigma, and it makes it bigger and harder to deal with. Health-related harms were particularly important in some of the more vulnerable communities, where it is exacerbating stress-related illnesses, contributing to comorbid types of health behaviors, even just the sedentary behavior, which is so important in terms of other areas of public health as well. It's also a challenging category in terms of separating the contribution of gambling issues to these harms, particularly regarding conditions like anxiety and depression, where it's difficult to parse the actual source. I'll mention that later in terms of the calculation of the distribution of harm. Cultural harms, as mentioned, separated out last. They're important issues to understand, and it is an area that we still need to do quite a bit of work on to get a better understanding of, and it's highly contextual. For work-related harms, we included any form of economic contribution, work, study, and voluntary work. One of the things we heard from several people was that gambling was pulling them away from where they used to do voluntary work, but also those people who then experienced problems with gambling found it harder to re-engage in those sorts of activities that gave them that connection and purpose, because people were suspicious of their history with gambling. Criminal harms obviously tended to occur in the most problematic levels of gambling. We divided them into 3 types. 1, crimes of opportunity, so people who are stealing resources, money, things to fund gambling. 2, crimes of neglect. For example, the common stereotype in the media about children left in casino parking lots. Interestingly, we also heard things around elder abuse, as well as some issues around people with traumatic injuries. Some of those issues are areas for further development and understanding as well. And 3, crimes of duress. This refers to people who are pushed into issues like drug dealing, prostitution, etc. to pay back gambling debts. Finally, the life course area, consisting of single or cumulative harms, as well as milestone failures, generational loss, and intergenerational harm. Each of these areas could occur for the person who is gambling, the affected others, or at the community level. So we had developed this framework and a large taxonomy of harms. And please see the full report published in BMC Public Health to see the full details of the framework and the developed taxonomy. Then we sought to measure the meaning in terms of population levels of harm. The best method was using the most common prevalence figure we have, which is the PGSI. We sought to map the different harm categories from our taxonomy to PGSI categories, which identify the level of severity of a potential gambling problem and its negative consequences, from 1, non-problem gambling, to 8, problem gambling with negative consequences and a possible loss of control. We selected the PGSI categories as a benchmark because most populations have prevalence figures for PGSI, since it is an accepted measure that is used internationally. We determined the occurrence of the different harm categories within the PGSI categories. Once we had done that, we sought to measure the harmfulness of those types of gambling. That was done with a large population survey using item response theory to separate out the harms to each category. From the IRT analysis, we created vignettes that describe what the experiences of harms could be within that category of gambling. We then went back out to another population survey, both with the general population and people with some expertise in gambling-related harm, treatment providers, policy health professionals, etc. We used 2 different methods commonly used in a number of health-related quality of life measures. The Visual Analog Scale, or VAS, which is a method that attempts to measure a characteristic or attitude that may range across a continuum of values and cannot easily be directly measured. It is often used in this kind of research to measure frequency or intensity of a sentiment. And the Time Trade-off, or TTO. An example of this technique will be explained in a moment. From the results of these 2 methods, we were able to calculate a disability weight, which reflects the severity of a disease on a scale from 0, being perfect health, to 1, equivalent to death. We applied that disability weight to the population and came up with our health-related quality of life lost for a calendar year for people actively gambling. These are a couple of examples of the vignettes we used for the Visual Analog Scale. It is important to note that there were hundreds of vignettes created, and there were multiple vignettes for each different category of PGSI from 1 to 8, and each person was only shown 6 vignettes to measure. You You can see a bit of difference between the PGSI 2 and PGSI 8 vignettes, and again, there's a lot of data in the full report. This is an example of what the participants were pitching the vignette descriptions against. The visual analog scale, shown on the right, essentially has the description of the vignette, which gets measured against other health conditions resulting from disease. If the participant hovered their mouse over any of the conditions, they got a short description of what the health-related quality of life impact was for that condition, and they basically moved the scale to where they felt it belonged in comparison to the other health conditions. The time trade-off shown on the left is, for example, if an individual is given a description of what their life would be like with a certain level of harm, they must decide how many years they would trade off to live in perfect health, such as, I'd rather just live 8 years in perfect health than live 10 years with that condition. Or with something that is a really intense and horrendous condition to live with, people may say something like, I'd rather only live 1 or 2 years in perfect health than have to live 10 years with that condition. There is a third methodology that is used frequently for these sorts of disability weight calculations, called the standard gamble, which for obvious reasons given our population, we felt would be too biased to use. From those calculations with the visual analog scale and the time trade-off, we came up with our disability weights, or utility weight as shown on the graph. That is, what is the loss of quality of life based on a scale of 0, meaning perfect health, to 1, equivalent to death, for the 3 categories of gambling provided by the PGSI, which are low-risk gambling, moderate-risk gambling, and problematic gambling. The ratings of the 3 categories are shown in turquoise. We took those disability weightings to our population prevalences for Victoria, Australia, because this was done just for the state of Victoria. To calculate the loss of health-related quality of life, we calculated using a QALY approach, which stands for Quality Adjusted Life Year. The Quality Adjusted Life Year is a generic measure of disease burden, which includes the quality and quantity of life lived. For this project, we used the QALY approach to determine the aggregate years of healthy life lost each year due to gambling in the Victorian adult population. We identified this as YLD1. The formula for calculating YLD1 is shown here. Using this approach, we could only calculate for a particular calendar year in which people are actively gambling at their respective PGSI level. Another measurement challenge is that we do not currently have a mortality envelope for gambling, which is a measure comprised of all deaths for a particular group. This is a big gap in gambling evidence, that is, what is the impact on mortality from gambling? We hear a lot of anecdotal reporting from emergency room physicians about people coming in with attempted and completed suicide where gambling contributed. We hear about people whose other health conditions are exacerbated through the stress of their gambling issues. But we don't catch this data in terms of the health systems. When you look at death certificates, there is no coding to indicate gambling as one of the underlying and contributing causes. Even for self-harm, impacts of gambling may be lost somewhere in clinical notes, but is not coded into the data capture that occurs in the health system. And certainly for me personally, that's an area I would really like to see change over the coming years. The formula indicated here shows that we have a single year that we're calculating for people that are actively gambling. We take the Victorian adult population multiplied by the annual prevalence rates for each of the 3 PGSI groups, that is low risk, moderate risk, and problematic gambling, multiplied by the disability weight that we calculated through the VAS and TTO measurements. This slide outlines the Victorian example, which is a population of about 5 million people. This indicated nearly 100,000 years of healthy life lost from gambling, and that's made up of people who are low risk, moderate risk, and the people who experience problems from gambling. We also calculated for the loss of quality of life for affected others. That added another 20,000 years of healthy life loss for the affected others, and we believe that is an undercount. Interestingly, if you take the whole amount of harm from gambling, just over 50% comes from low-risk gambling. And as mentioned before, this backs up a concern mentioned by the Australian government's Productivity Commission, flagged in 2010. This is purely because of the size of the population that is gambling at the low-risk level. Traditionally with gambling, we've been very focused on that 1% who are experiencing problems from gambling or are gambling pathologically, and we've pulled those apart to see what is different about them. But if you move away from this idea of problem pathological gambling and start thinking more broadly about gambling-related harm, you'll see that it changes our focus entirely. 15% of the harm comes from that problem pathological level. It is very concentrated in a small number of people, but if we're thinking about population-level harm, we need to broaden the focus out. So what does harm look like for low-risk gamblers? We've published an article in the Journal of Gambling Studies, led by N. Lee, which focuses on item response theory, and it explains the breakdown of which harms occur in which category. This slide provides a broad picture. what was really surprising to us is the self-harm and suicidal ideation that was occurring as low as PGSI 2. People ask, what does harm look like to someone gambling at the lowest level? I think the important point is that it is diverse. This is not a homogeneous population that gambles, and nor is the experience of harm for those people. It can be any of these identifying harms being flagged by people in low-risk gambling groups. And you can see that, in terms of responding, this is the challenge, that there is a broad range of things that need to be addressed. We then started to look at those who were harmed and started dividing them up by age, gender, and other differentiators. There has been a real focus in recent years on young men and gambling-related harm, especially because of the levels of them that are experiencing problem and pathological levels of gambling. But interestingly, they are not the group that is contributing the most harm at a population level. When we broke it down by age and gender, we found females 55 and over in the low-risk gambling category accounted for 14.5% of the gambling-related harm pie. That is an interesting finding, as you're looking at women who are, in terms of life course theory, experiencing things like empty nest syndrome, separations of marriages, transitions between work and retirement. And when you start to look at some of the evidence that is already out there on women and gambling, you see the lure of the gambling environment as a safe place to go to socialize and for entertainment. So it starts to raise some interesting questions about how we respond to this particular group of people within the population. Interesting also, males 55 and over at moderate risk gambling levels contributed over 13% of that harm. Here are some limitations and criticisms to the methodology. It's not perfect. It's the first time it's been attempted, and we've now run it in Victoria, Australia, and New Zealand. And there are things we'd like to do to improve the rigor of it. For one thing, we are constrained by the data that's available to us. The first area is the issue of overcount. There will be a conflation of comorbid effects. For example, if someone is experiencing gambling harms, but they also experience depression and anxiety, it's quite likely that people will attribute the harms that they are reporting to the gambling. We're looking at ways of disentangling those comorbid effects, such as looking at things like population attributable fractions, which is the proportion of cases caused by problem gambling. We need longitudinal data to do that, which is a challenge. The one study we found that had looked at sequencing found about a 53-47 split between the depression and the gambling. So there's likely a small overcount in the disability weight that is applied to gambling because it will capture some effects of depression, anxiety, and other comorbid issues. But the overall loss of health-related quality of life number is a massive undercount. The reasons being that it is a single-year snapshot, that we haven't got mortality envelopes, and from an epidemiological perspective, that we can't do a disease model at the moment for gambling, because we don't know duration, how long problem gambling lasts before people recover, and we don't have incidence, which is the rate at which new cases develop each year. Without duration or incidence, we cannot look at the issue of chronicity of these harms. That is another area we need to be able to work on, and we've recently secured some funding to do some early pilot work on that. The biggest reason the overall loss of life measurement is an undercount is because we haven't even begun counting the legacy harms. Our measurements are only for people who are actively gambling in the given calendar year. So for anyone who's stopped gambling for over 12 months and who doesn't register on the PGSI in terms of being at low risk, moderate risk, or problem gambling levels, we cannot count the harms that they still may be experiencing. We are looking at some ways we can start to capture those legacy harms, which is again very challenging from a methodological perspective, and we'll be doing some early pilot work in these areas as well. As mentioned, we do not currently have mortality envelopes, so we have years lost to disability, but we haven't got years of life lost in that calculation. We're continuing to work to strengthen these measures, to further develop the methodology. We're interested to work with collaborators who can help us access better data to strengthen the methodologies and measures, so we look forward to continuing this work. This work is changing our focus. We've got to stop focusing on the problem gambler. We need to start talking about gambling-related harm instead of gambling problems if we want to address those harms and minimize them. The Australian government's Productivity Commission used the analogy of the ambulance at the bottom of the cliff. We need to stop those people from getting to the cliff face, and a lot sooner. We need to broaden the concept of gambling-related harm. The focus on just finances is too narrow. Harm is a lot more complex than just the money lost. We need to stop looking just at the person, we need to look beyond it. The fact that there is so much harm occurring at the low-risk gambling level suggests we need to broaden our perspective, start looking at issues around the policy response, the safety of products, the environments, accessibility. These sorts of things are going to become more important to consider. How do we work towards creating prevention in terms of addressing issues as people start to engage with gambling from early on? How do we ensure that they're not going to experience harm? How can people actually enjoy gambling as a legitimate recreational leisure activity and be more protected from experiencing harms? The early screening for harm, not just behaviors, such as the PGSI assessment, is important, and starting to include measures of harm in some of our population surveys as an indicator of harm minimization. Just measuring changes in PGSI prevalence doesn't give us a good sense of the impact on the community. We need to work towards ongoing improvement of these measures, particularly issues around mortality and morbidity or illness. We have just finished work with Professor Chris Duran, an internationally renowned health economist, where we did a social cost of gambling, where we've taken our taxonomy developed in this project and calculated the economic cost of gambling-related harm. There are some interesting findings that will be released from that in the coming months. So I would encourage you to sign up for VRGF's Gambling Information Resource Office alerts to stay updated on these new projects and publications. As well, we've developed the framework used by the Productivity Commission, and that has very important policy perspectives. We're doing ongoing secondary analysis of the very rich data sets, starting to look at things like harms for children of people who gamble, differences between spouses and their experiences of harm as an affected other, and other questions like that. References for the work mentioned in this presentation are included here, including the full report that is the subject of this presentation, published by BMC Public Health. Thank you for listening to this presentation, Understanding Gambling-Related Harm, Separating the Behavior from the Outcomes, by Erika Langham, which was part of the GREO Policy Forum on Defining, Measuring, and Mitigating Harm on January 24, 2017. Full reports and links to resources and items mentioned in this presentation are available in the GREO Expert Panels Resource Center, accessed through this webpage.